Assalamu alaikum again. I've changed the agenda a little bit now. I think the most of this discussion about withholding and withdrawing treatment and these things which will come out of discussion more rather than the talk. So I've just replaced the things a little bit. But in order to set the scene, what I'm going to do over the next half an hour, and then we should have the discussion before I go on to the death certification, because that is very applicable to the community. So what I'm going to talk about, because I just thought what I need to really explain, and that might sound very basic, as I said earlier, but I have got a special interest in that, is dying. The pathophysiology of dying, actually. How do people die? That becomes important. Because a lot of the discussions we are having, is to support the patients and the families, but also for us as professionals to understand that what do we start seeing is happening in the body. And I'll explain that in a second. And this is why it is important. Anybody knows this lady? Sorry? Oh. No. Name is written, Dame Cicely Saunders, but who was she, meaning? Cicely Saunders was the founder of modern hospice movement. She started, so hospices used to exist, but this, as I explained earlier, they existed in parishes. She was a nurse in the Second World War. And this is inspirational for me. And then she decided that what the human suffering she was saying, she came from a very wealthy background. I had the delight of meeting her in early part of my career. She died in 2005. She was a nurse at that time. And then when the war finished, she came back and started working at St. Tommy. And this is important because as a nurse, she was a very powerful and strong and very knowledgeable woman. And I heard her say it myself, so I can quote her. She said that she was doing the ward down, trying to make suggestions to the consultant. Forgive me for telling that, but there was a surgeon. So consultant surgeon was there who basically said, Madam, you are making a lot of comments. If you really want to be making any difference, become a doctor. Which was very ouch moment for her. So she trained and became a doctor. Only to realize doctors don't do much. They don't bring, so she then trained to become a social worker. During her journey, she looked after a patient called Tatsuma, who was a Polish artist. And he used to draw at St. Tommy what he was going through. And his drawings became famous as, and I have seen it, so I haven't put it there, but the pathway to suffering. He had colon cancer and he was deteriorating, and you can understand in 1960s there were much less treatments around, and he was just drawing what he was going through. Cicely was inspired by him, and this is how she started St. Christopher's Hospice with the help of Robert Toycross, who was a pain consultant, and Colin Murray Parks, who was a psychologist, because they decided this is how the good death should be achieved. And Cicely then, interestingly, herself got colon cancer. And she died in 2005 at St. Christopher's Hospice. And she said this, and this is what inspired most of us. How people die remains in the memory of those who live on. And this is what I believe we should be achieving. It will be easy if somebody gets disease, deteriorates and die. And this trajectory is very famously used in cancer. So you get cancer, you deteriorate, and one day you die. But like it was mentioned earlier, but the reality is that cancer only still is not the commonest cause of death in the world. Do you know what is the commonest cause of the death in the world? No. We don't even think of it actually, because when you live in West for a long time, even it slips my mind. It's no. Sorry? nearly there, infection. It's one or the other sort of infection. And here we think infection is, because it's so much treatable, we don't think of it as a cause of death. You get mortality meeting when in the hospitals when somebody dies of an infection. But that's the reality. And many patients die of what you just said, heart attack, very quickly. How much time of palliative care is left? Then you see these patients, dementia, Parkinson's, multiple sclerosis, heart failure, goes on and on and on for a long period of time. And you still have to do your part as community. But then you've got this. Patient gets worse, better, worse, better, worse, better. Then you'll be asking, is it not the normal patient? No. Because if you look at it, every time they get better, they are not able to get back to their baseline. And that's a good direction for you. How should we be managing them? This is where we start planning, thinking, and doing the things right for them, because there's no chance back for them. We talked earlier about their capacity and autonomy. Every single episode is hell for them. When they wake up, their mindset is again scared, frightened, and angry, and depressed, and they're not able to make their decisions consciously. So we need to get there when we start seeing that, to support them. And this is where the problem happens when we are talking about advanced decision to refuse treatment or withdrawal of treatment, withdrawing. If you're sitting like that and you're telling these patients, we'll be withdrawing treatment from you, leave alone faith part, I can tell you it is hard. Because this person is saying it is every time you are giving up on me. And this is got huge psychological impact. So we need to really get it compassionately right. We talked about surprise question, and I will try to be quick here. So there are a lot of indicators which tell us when people are dying, and there are frameworks. It might not mean much for most of you, but this is how death occurs. There is a term called cachexia. Clinician might have heard of it, other people might not. Cachexia literally means extreme weight loss, that's all it is. Extreme weight loss is the first indicator that you have got few months left. Why did I put it there? Do you know who was the first person to document cachexia in the history? So if any clinician in the and this is a very interesting thing for us to learn as community. Not person's name, but his thinking behind it. It was Hippocrates. And if you guys know, Hippocrates lived thousands of years back. But his observation was important, which we need to understand. He said, cachexia is a horrible disease. Whoever gets it dies within few months. Important message for us. He picked up, patients die. We need to plan for them. We need to get it right. We need to support them from now onwards. Why it happens, when it happens, that's not that much important. So I will miss all that part and try to talk about last days of life. And if you look at the last three, one which I've made bold, cytokines and loss of adipose tissue, that all happens. So there are different things which happen in the body which make us think we are approaching the last days of life now. This is where our further discussion will come about withholding and withdrawing treatment. Because withholding and withdrawing treatment should not be based clinically, we are stopping the treatment. It is based on, must be based on science. You only give the treatment. For example, again, the word might not mean much for you. Let me explain. Hypoproteinemia. It means low level of protein in your blood. Now, if I ask most people, what do proteins do to you? You will talk about energy and muscle mass. If you ask a doctor, especially working in end of life, like me, what do proteins do for you? The only thing I know they do for you is they carry the medications around in your blood. What does it mean? If protein level is low, the drugs they can take around is not possible. So you need only those medications which can be taken around to be effective. If you give 15 drugs to them, We published some paper back in 23 in which we looked at different hospitals, lots of hospitals actually, and we tried to calculate how many doses a patient has prescribed, not whether they receive it or not, in the last week of life per day. So for example, one drug is given 4 times a day, so that's 4. The second is twice a day, so that becomes 6, right? Now, it's not rocket science, so anybody can answer this question. What do you think was the average that the patients were prescribed medication for the numbers in the last week of life per day? How many medications? 1, 2, 3, 4. Sorry? Thank you. 33 actually. If you are giving a medicine, 33 medicine per day to a patient whose protein is so low, you know what you're going to do? You're going to kill them with those drugs. Because these drugs will float around rather being carried to the right end point in your body and cause more harm than good. So when you're talking about withdrawal of the treatment, it must be based on science. It's not that these drugs are futile. They are killing you now. They're causing side effects. They're making you suffer more. And not being... A question was asked earlier to Maulana as well, that actually if the medication is not working, should we be stopping them? Well, don't know about from clinician point of view, if they are not working, but more importantly, have they got potential to do harm? And they're harming you. Then in my personal, very humble opinion, I have a duty to stop that. Because I do not want to harm my patient. That's how my clinical mind thinks. Obviously, if we are causing good, then that's different, a completely different story. But I need to pick that up. Second thing is, cytokines, let's leave it, but loss of adipose tissue. What is adipose? It's fat. This is a scientific word for fat. Why is it important? You see, I mean, none of you, I'm talking about me, I've got a lot of fat. But you can see it like here and some particular places. But when the patients are in the last days of life, fatty tissues are the last defensive mechanism for you. Where do you lose them from? Face. Under the skin. So some clinicians who are here, they will remember when the patients are dying, they develop some blue sprinkling. Well, we live in a country predominantly Caucasian, so white people, their skin becomes bluish. And we just worry about what is happening. Do you know what is happening? That thin line of fat, which is the last defense mechanism, is gone. If the last defense mechanism is gone, you need to really concentrate on keeping them comfortable, because you have got no no protein, no fat to defend you, carbohydrates are gone anyway, electrolytes are gone. What's going to keep you alive? This is the science of death and dying. So when I'm trying to, the reason I'm saying not to, please forgive me if I'm trying to sound a bit like I know it all. No, I'm not saying for that reason. I'm just saying there is a good case to understand how people die. Only then we can make the right decision. And this is when we need to look after ourselves as well. So hopefully, I will just put one more slide on before I move on, is we need to strategize to help ourselves. Because this is otherwise, I know, I was just hearing the discussion there as well, we are always in this turmoil. Am I making the right decision? Where am I going from here? Because if I didn't, I do not know about my patient, but I'm definitely harming myself. Oh, well, I'm harming my patient as well, but I'm me as well. I'm not being selfish. Because those memories stay in your mind, and you move on to the next patient, and the next patient, and the next patient. And I have seen enough doctors really getting burnt out and having difficulty managing the patients. Why? Because they did not pick those things earlier. Interesting question to you. Do you think within medicine, which field has got the worst burnout? Any idea? Sorry? A&E. A&E is there on the top, but not the topmost. ICU is also quite high, but not. ICU is not. No, sorry. ICU is not very high actually. People who remain in ITU remain in ITU. Psychiatry is quite high as well, but not the highest. It's plastic surgery and burns. And I know the reason because my house job about 30 years back was in burns, especially in Pakistan. When they come to you, they don't survive. And who are the people who get burns most? Young people, children. And it was so hard for me to see everybody walking in and dying. That was my first job as a doctor. So I completely understand. What the point is that we did not look after those staff. But I tell you what, do you know which field I will have to ask, top 3, which have got the least burnout? Yes. Okay, answer is there. So first is neurosurgery, but the second is palliative care. And you'll be thinking that we are looking after dying people all the time. Why don't we run away? It's because of this. We need to look after each other. That is complete recognition. And you will have different tools to do all of that. But as a community, when we move out to look after our colleagues, our friends, our neighbors, our community members, we need to look after ourselves. And my real hope is, after today, we can actually come out with some plans in which we develop a strong community to look after our community members who have to go through this. So I did not talk about withholding and withdrawing treatment because we have had enough of that. I just wanted to give a scenario on why do we withhold and withdraw treatment from clinical perspective. But I really now want to hear from you guys. What do you think? And obviously, Agha will be better placed than me.
So we are going to open up questions for about 15 minutes, and then we're going to have a presentation on organ donation, which will be really excellent as well, and then we'll come back to the other elements as well. So that you can see on the agenda item. A couple of questions have come through from Slido previously, which we didn't have a chance to address. One of them was doctors have been forcefully encouraging elderly patients to sign the DNAR form. We keep saying DNAR, but I hope everyone knows the DNAR form, just to remind it, is do not attempt resuscitation. Just a reminder in case anyone had forgotten. To DNAR, is this correct?
Thank you very much. First of all, like I was saying, DNA-CPR, so do not attempt cardiopulmonary resuscitation. And I'm sure everybody knows, but cardiopulmonary resuscitation is a combination of pumping on the chest, so like boom, 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 jumping, and then giving you electric shocks. I think I explained earlier, but let me go back there again. A clinician will make a clinical decision whether this treatment is going to be useful for you or not. If it is, there is a chance it will be useful, they have a duty to do that. If the chance is that it will not useful or harmful, then they need to make a team decision whether to not offer that. For example, we just heard from experts my brother there about the transplant. And I'm sure they will agree that you do not go and say to everybody that you will have a transplant. You need to pick up the right patient to have that and right resource. So if that CPR is going to be helpful for you, but maybe not for you, we know the evidence is telling us not going to do that because of the combination, then doctors have a duty to do that. Usually it's 2 doctors, 1 junior, 1 senior, plus a senior nurse who will make the initial decision. If you challenge that they need to take you to another colleague to gratify that. Remember, as per law, we cannot demand treatment. I'm just talking about law, not fiqh here. But we can refuse. So patients can only refuse CPR. If the question is that patients were coerced and made to say that you do not want resuscitation, that's collusion and that's illegal. And that is punishable actually by custodial sentence if somebody did that. But you do not sign anything. The signature will be done by the doctors on the CPR form only if you are using it as an advanced decision to refuse treatment. And if you are colluded into that, anybody, it's a crime in this country.
Okay. I think we're able to maybe take one more question if there's anything. Okay, lovely. Please just say your name, where you're from, and your role.
My name is Fazilat. I'm from Milton Keynes. I just wanted to ask and share a little bit of a personal bit behind it as well, where it comes on the question of withholding or withdrawing treatment. Unfortunately, it's something that I'm going through with my mother currently. And what you showed on that chart, I'm sorry, it's very true. She goes up and down. She keeps on asking the same questions as well, like as if to say, why can't they treat me? But it's not because the treatment is not available, it's because of our own health, and that conversations that you have are very difficult. And it's harder because you understand where the treatment is being withheld. It's not being withheld really, it's just not right for her. So yes, the patient needs support and the caregiver needs support, and I 100% agree with that. And alhamdulillah, the community has been brilliant. I've got two lovely ladies here who visit mum regularly. But watching that chart just brought it home that yes, she's never going to go to that level, and to treat it and to explain to her, because she asks every day, why won't they do a biopsy? Why won't they give me a diagnosis? Why do I have to have so much pain relief? She's in pain, she's in terrible pain. But for her to receive that treatment, why is this happening? A very independent lady, has done everything for herself throughout her life. But because she's asking those questions, it's making us harder and harder for us to respond. But as I said, clinically I understand, but it's just to make her understand that is harder. So I really, really appreciate the topic that's been raised, and also to tell, let everybody else know that yes, it's a hard conversation, but it can be done. When we're in front of her, we are extremely strong. We're explaining to her, we're taking her through each of the stages. And the advanced care, we have also gone through that conversation with her. It was very difficult. As you said before yourself as well, especially particularly when it's your own parent, to have those advanced care. Now, right now, I was waiting for Eid to be over so I can have a conversation with her about the respect form and, what her choices are and what she wants to do. Again, another difficult conversation to take place. But then again, you're choosing those moments just making sure that she's also in the right frame and she understands where you are coming from. It's not a question of like saying, okay, so you're going to die, what do you want me to do? But it's those conversations to be done in the right time and the right place. Thank you.
Yeah. Yeah, please.
Thank you, sister. First of all, really sorry to hear that, and it's very close to home. The discussions you are having are very brave, and it's really impressive that you are able to do that, because I don't think that most of us in our hearts will be able to do that. Thank you. The pain of it is the price of love that we have. You love somebody more, it will hurt more. And that's all I can say. So really comment for your comments.
Yeah.
Thank you for that.
Thank you so much. I think we're going to move on to an organ donation discussion, but I think I would just say thank you again from all of us, because I think one thing we're obviously talking about things that in a theoretical way, but I think all of us have been there at the forefront with the patients, and it's a different situation altogether. I think just a reminder for us really that all of this is to serve patients that we're looking after, and our family members and our community members as well, and this is a very heavy and real thing. So really appreciate you sharing that with us. We'll now have a discussion on organ donation and other issues from Syed Rizvi, please.
أعوذ بالله من الشيطان اللعين الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا ونبينا أبي القاسم محمد وعلى أهل بيته الطيبين الطاهرين المعصومين أما بعد السلام عليكم again everyone. We have been talking about the organ donation and transplantation on and off in different contexts, but I thought maybe I'll share some slides just to put all this issue all in one place. Is this showing the screen? This is okay. Now I'll try to make it very brief and simple, maybe then go to question answers. You know, as we briefly discussed before, when we talk about human body, we have to realize that is also governed by, you know, the divine laws as we see in the Quran and the Sunnah of the Prophet and the Imams. And so there are limitations on what we can do and what we can't do as far as our bodies are concerned. The example I'd mentioned in one of the questions was that, for example, we cannot decide that we would want to be cremated. You know, the process in Islam is burial. And if you look at that, it's right in the beginning. The first murder or death in human history was, you know, Habil killed by his brother. And there the whole story, you know, Allah subhanahu wa ta'ala, it's amazing that Allah uses the crow to teach the human being, you know, how to dispose the body there. And so the point is that, you know, there are some limitations. The primary and the fundamental rulings is that the Muslim's corpse is to be disposed in a dignified way through a very special procedure of the ghusl and the kafan and even the burial. And so now let us look at the issue of the organ donations first during the time when we are alive. There is a difference of opinion, interestingly, even between the Grand Ayatollah, who was Ustaz al-Mujtahideen wal-Faqara, Sayyid al-Khoyi, and his own students. For example, when it comes to the donating organs during lifetime, Sayyid al-Khoyi allowed it, provided it's a minor organ, you know, blood or skin graft or bone marrow, things which can regenerate. But when it came to major organs, he did not allow that. When it comes to, this is where you see the difference even between the teacher and the student. Sayyid Sistani, Sheikh Makarim Shirazi, and Ayatollah Khamenei, they actually allow you know, organ donation during lifetime. They do not differentiate between minor and major organs, provided the donor is not seriously handicapped by donating. So, for example, unlike the opinion of Sayyid al-Khoyi that you could not donate one kidney, according to Sayyid Sistani and Ayatollah Makarim and Ayatollah Khamenei, it is permissible. But I think the main issue that we have is the issue of, can we donate organs after our death? On this issue, Ayatollah Khoyi and Ayatollah Makarim are on the same page. And they say as long as you express your intention clearly in your wasiyyat and your will, then it is permissible. Sayyid Khamenei also agrees to that, but he puts kind of a where he says it is permissible provided the body does not look like a mutilated body. Now, he doesn't explain much about it, but the way I would understand is that probably retrieving organs from inside would still be okay, but taking out something, I don't know whether it's going to be done or not, where the body looks like it's missing something, eyeball, yeah, that example, then that would be like a mutilated body, and that wouldn't be allowed. So internal it would be okay, because then it's all in a way packed up. You don't see much there. But when it comes to Ayatollah Khoi's two students, Sayyid Sistani and Marhum Sheikh Jawad Tabrizi, they actually say such a will is not even valid. They do not even accept the validity of will made about donating organs after death. And I checked the issues. He has not even put the term, say Sistani. He doesn't say ihtiyat. He clearly says no. Otherwise, you would have an option of, doing ruju to al-a'lam fal-a'lam, second, tier mujtahideen. Then we go to this issue. I hear quite a lot from people, Muslim, non-Muslim issue. I think there's a misunderstanding there. In the cases where the mujtahideen have allowed, whether it's Ayatollah Khoi or Makarim or Khamenei or Sistani, wherever they have allowed it, then there is no problem in donating that organ to a non-Muslim. Because I haven't seen any statement of that kind. That's a different issue where they talk about, if life of a, let's see, if in the very extreme situations where they talk about a life of a person depends on retrieving an organ from a dead body. There, those who say no, they say no. Doesn't matter whether the person who needs that organ is a Muslim or a non-Muslim. But in cases where they are allowing, they are not differentiating between Muslim or non-Muslim there. Sometimes people say, well, oh, Maulana, he will go and do things around with my organ. Don't worry about it. It's Allah's job to find out who is doing what. It's not your business. He will do the judgment on the day of Qiyamah. So that's not an issue here. There is no problem then also in transplanting a non-Muslim's organ to a Muslim's body. When we talk about, taking an organ for a non-Muslim to the Muslim, after the initial process, after a few days when that organ is transplanted to a Muslim's body, according to the rule of mutahirat, intiqal took place. After a few days, that organ is no more known to be of a non-Muslim. It is of a Muslim. So this issue of, tahara al-najasat also is not an issue. People sometimes start reading very deeply into it, more than necessary. Not only that, there is no problem in transplanting an animal's organ, whether a baboon's heart or a pig's organ, to a Muslim's body. Again, you say, oh, you're talking about ayn najis animal, You have to remember again, this intiqal when it takes place, that's okay, there's no issue. Especially, I think one of the early heart transplantation was from pig, eh? Yeah, in South Africa. Yeah, so, and it's going to be inside anyway. Many things inside our bodies najis anyway. You don't have to worry about taharat and najasat there. One relevant question which comes up is the issue, the extent of parents' rights in, donating organs of their child. This is a very, difficult issue. According to Sayyid Khoy and Sayyid Sistani, they say no parent has a right to donate his or her child's organs to anyone. Their right does not extend to that level. However, Ayatollah Makarim and Ayatollah Khamenei, they say they recognize this consent of the heir, whether parent or anyone else who is the warith, is sufficient for extracting an organ from the deceased. So whether it's a adult or a child, they do not differentiate in that. And so this is as far as the organ donation and transplantation is concerned. I actually have a 2-page write-up on the website that we have, Al-Ma'arif. You can even get that in it's in a question-answer form. At the end, I talked about this issue. Some people say, Maulana, what are you talking about? Muslim, donating an organ for someone else. What will happen on the day of Qiyamah? Where will it go? and this is where I say, you recite Surah Yasin every Thursday night. Look at the last ayat there. Allah subhanahu wa ta'ala says, you are surprised about this resurrection. And this is what I say, it's his problem, his business. It's not our problem. He will take care of that. And so wherever it's allowed, that wouldn't be an issue for us. So maybe we'll stop here and see if you have any questions. Then a little bit I would like to talk about the issue of intervention.
Just a question for Professor Saab, please. I should know this as a community person, but I need to clarify it myself. You mentioned that we have to proactively opt out from organ donation, right? Otherwise, the system has the choice to remove the harvest the organs or not. Is that correct?
It is.
Okay.
Yes.
So, let's say somebody, especially in our Indo-Pak community, they're not even aware of these things, especially the first generation migrants who are here getting old. What is the role of their immediate family members? The kith and kin as is considered here. Do they have a role in denying that to happen, or is it no?
Okay. The law is not practiced as much, and I know, but if you look at the black and white law, it has been approved by the parliament as an act of parliament. So only a king's ruling can rule it, which again takes the advice from parliament. I think there are lots of things we do not know about what happens about death and dying and the law in this country. If I ask everybody a simple question to help answer this question, does anybody know who does the body legally belong to when you die? Legally, I'm saying. Whose property is it?
Charles' estate.
King Charles. It's belongs to crown. Till the crown gives, till you are able to register a death and you are issued a death certificate. And the reason behind that is clear. Because what they do, the state has got a duty towards you personally. So what if your wife or husband has killed you? So that's why they are all withdrawn. Your body is taken till the death certificate is issued with the agreement of one doctor, one medical examiner and the registrar. Then the body becomes back, is returned back to you. Again, the body can be exhumed by Crown's order to do a postmortem at any stage. So we do not have, so we have to accept that there are some, although these roles are rarely practiced. So the same applies here as well. It is not very much practiced, but if the state is in the need of liver, kidneys, and the law is there, so you need to opt out before rather than opt in. So the state can decide.
What you're saying, I mean, to imply it, for my own understanding, is the fact that if the immediate relatives raise a hue and cry, no, 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 then they might be considerate enough. The law is not actually practiced.
It's not. So families are usually, but I have been involved in at least one case where it was felt that patient wanted it and the family is, so it was not a Muslim family, it was another family where the patient, the nurses actually went, the patient actively spoke to them about donating, and now the family was stopping it. Then the law was practiced.
Thank you, Professor.
Any other questions?
Sorry, I just wanted to give some guidance from an admin point of view, working in a GP practice. What we do suggest that if you've had that conversation, then the patient themselves can make a notification to the GP practice and told them that they will not be organ donors.
Thank you. Thank you so much. That's good point.
Okay, we'll return back to the presentation.
I would suggest that, Dr. Abbas mentioned that it's not being practiced, the law is there. So I think that creating that awareness is still important. I think all the community members should know about it. I think you have that in part of the driver license thing? Eh?
Not now.
No, not now, okay.
But because it assumed you don't need to write on driver's license.
Oh, okay. Because in Canada, it's optional. If you sign it behind your driver license, then it means you are allowing it. Okay.
Yeah, it is opt-in by default.
Okay. Yeah. Okay, then I wanted to go on to this issue of intervention in illness. Now, we talked about it just briefly to cover some points all in one place. If the patient is suffering from an illness that has a cure, then it's absolutely essential to intervene medically in order to save that life. Because the cure is there, so it is wajib to intervene medically in that way. In this case, withholding intervention would not be right. So whether it's treatment, nutrition, or normal comfort, or palliative care, whatever form that we are talking about, that has to be maintained there. I think the challenge that we have, as far as the opinion of our mujtahideen is concerned, is when there is no cure. There are two different rulings. One is the issue of withholding intervention, and the other is withdrawing or withdrawal of intervention. And this is something, again, I would say we need to educate our community members about this issue. And it's not only announcing it once. I think, this should be an ongoing education process at least once a year in a large gathering. Not necessarily in a majlis, but you can have a special presentation of 10, 15 minutes in a program that this is a medical issue that we would like to the community to know about it. Because when families face, this is what I've seen, they only come to think about it when they are faced with that challenge. If they knew from before, then they would have been ready to deal with it. So when it comes to the withholding of intervention, it is permissible since medical science has no cure for that illness. So withholding that I don't want to go through this would be okay. But the problem that we have and the challenge that we have, let me see. Is the issue of withdrawal of the intervention, especially when we talk about life support. This becomes more challenging for us, and the current view of the Shia jurists, that as far as I know, is against withdrawing intervention. Once it is, the life support has been put in, you can't do, from the Shari'i point of view, you can't withdraw that until the heart stops. And so I think, this issue of to be aware of the choices before the patient reaches the stage of being put on a machine, the decision to withhold the life support is easier than to withdraw it. And so this is, again, is something which must be communicated and talked about to the people, so they know about these issues. And this also helps them in making their will, or even when they talk about power of attorney and things like that. Awareness of these issues from ahead of time would be helpful. Now, personally, I have, challenge and difficulty when I see situations where a person was put on the life support, because sometimes it happens that the family member were not there, there was no directive from the patient, and heart attack happens, and they automatically, they will revive the patient and put the patient on life support. At least in Canada, if they don't have the directive from before, this will happen. And then to remove that becomes a challenge. And this is where we see that if it was in a situation where there is no cure, nothing, it looks like that maybe, it should have been easy to withdraw. But according to the fatwa at the moment, the way they are, we are not allowed to do that. And so we have that challenge and difficulty on that issue. And that's why in most cases I just say that, ask the hospital or the doctors, because in Canada a year ago the law was passed that the medical authorities, if 3 of them agree that the life support has to be withdrawn, then even if the family is saying no, they have a authority to do that. And so it becomes very challenging. I haven't seen a case like that, but they have the right to do that. In most of the cases, they, as I said in the morning, that ask them for 2-3 days, and they allow that 2-3 days grace, and the patient, goes through that heart death within that time, mostly. And so I'll conclude there, yeah.
I want to, I think that last slide has raised some questions, certainly for me. Maybe if I can take advantage of having the microphone here and ask a question, which is the confusion, I think, which many have discussed in the break, and perhaps is one that we can untangle a bit. We have somebody who we don't know the certainty of their prognosis. So there's no cure, because as has been mentioned today, 86% of conditions there is no cure. 14% we can, but the rest we're managing. This person then becomes unwell. We must give them all the support they need. So we give them the support. That would include life support. The problem is now they're on life support, which could sustain them living indefinitely on a machine. Everything is going in the wrong direction with regard to everything else. Organs are shutting down, bloods, etc. However, we can sustain them because they can be on this machine. So how does, I think that is the question many of us have in our mind. How do I square that circle?
I think the challenge is more about the issue of life support, not the medical interventions before it, as far as nutrition or medication and things like that is concerned. So we have to separate the two issues here. If we are talking about intervention by giving medication or nutrition, as long as that is possible and the body is able to take that, that has to be done normally or through IV or tube. But if the body doesn't respond to that and it creates more complications, of course, then you can't really do anything. The bigger challenge is the issue of the life support at the end. And that's where the opinion of the Maraja is that you cannot withdraw that.
So I think I don't know if there's any ITU or interventionists here, but I think the thought is, certainly one of my friends from medical school who is an ITU consultant, the thought is that intervention through life support is an intervention. So the challenge is the nutrition, all those things is one element, but the thought from him would be intervention, life support is an intervention, because in that interim time we're supporting that person, allowing them to get over the infection or whatever it might be, and then hopefully their organs have a break and then they can take over. So I think that's where just to tease it out a bit more. Any thoughts from yourself? Or anything I've said incorrect or to add, or left Maulana Sahib in the hot seat? Yeah, nice.
Yes.
Let him have the answer.
Let's go to the next question. Let me think about it.
Sure, sorry. Okay, so we've got Dr. Nizar Morali here, please.
I just want to comment.
Just take the mic and just introduce yourself, please. Again.
Nizar Marali. I'm sorry I wasn't here this morning, and I'm sorry if it has already been covered. But did we discuss about what is death?
Yeah.
Yeah. So brainstem death. So in this instance that you just illustrated, if it's more than 5 minutes and the brainstem has died, in other words, that person is no longer able to breathe, and his circulatory system is no longer able to be functional, then at that stage, there's absolutely no advantage in putting him on ventilation. So what Maulana is trying to say, make the decision at that time. Don't put him on a ventilator such that you have to then withdraw it invariably, because he's dead already. You're just trying to sustain his circulation, his breathing by a machine, but he's already dead. So make a decision at that time and not to put him on a ventilator. I think that's how I understood it.
Sure. I think the challenge, this is really going to be the crux of a lot of the discussion, which is there's a lot of grey here. So I think it's not just about the brainstem death. It's also the fact that there'll be patients who are not brainstem dead, but who need life support to support them. But of course, the trajectory of what happens after they're on life support is impossible to gauge. They could improve, or they couldn't. And if they don't, that's the challenge, I think, because they're not brainstem dead, but they're basically being kept alive by life support. But we're going to continue to move on to another question. Any other questions or anything from the floor? Just a name and your role and everything.
Mohammed Karmali. I'm a doctor working in South London. I wanted to ask Maulana, I think you mentioned that there is a distinction between illnesses that are curable and incurable, and the ability to treat that. I think often there is the case where illness can happen, or rather a curable illness can happen in the context of an incurable condition. So for example, someone that develops a chest infection in the context of a neurological incurable disease. In such cases, you might treat the initial infection. The patient, for example, improves clinically. Then they develop another infection as a consequence of their incurable illness. Again, you treat the infection. But the broad trajectory is that they are developing more and more of these curable, however transient, illnesses because of their incurable condition. How do you go you know, as a clinician, how does one circle that square, as it were? Do you continue to treat them, or do you when do you say no?
So basically, yeah, go ahead.
Sorry, we don't want to turn into a clinical class, but the question here is, what if they are having superimposing infection after one after the other? I think there are good clinical criteria if you look at the evidence base for repeated infection in terms of incurable disease. For example, if you are having pneumonia, recurrent pneumonia for motor neuron disease patients, and if they are recurring within this space of time, then we know that infection was never cured, because that infection has persisted to continue on. And there are good documents on it, evidence-based, which will say, actually you need to decide yourself, are you treating the infection, or actually are you just prolonging, because after if you don't treat it, the outcome is going to be the same as if you treat it, which will be a late infection to cause the death. So I think first thing first, what we need to make is a good clinical assessment to come to the point that in terms of prognostic criteria, is this your word, curable on the top of incurable, really curable, or it has always been incurable? And as I said, I mean, this is a clinical class which we can talk about later on, working on that. But then the next question is, what if it was cured and then it keeps on coming back? Clinical answer will be, then you need a hospital at home case workload to basically keep them in touch and given it. And sometimes you are giving them things like gentamicin nebulizers for the rest of their lives, so that you can prevent their suffering from that. It depends on what the local protocols are as well. So that's the clinical answer.
Well, we're just going to switch to one. We've got one more presentation before a small break, but I can see a question here from should be. Oh, yeah, please,
Okay.
yeah. Sorry, forgive me.
I think the illness itself is incurable, but you are saying that that person also, let's say now, has infection, so you treat that, and after some days again it becomes a recurring situation. Because the illness is separate and then you have the infection happening, there is cure for infection, so you do it again. I haven't seen any opinion which says, okay, maybe after 5 times then just forget about it. Because it is curable, you know, that side problem, you will have to deal with it.